All right, everybody, if everyone could take their seats, we'll start off with our first keynote lecture. I wanted to give a brief introduction to a man in orthopedics who needs no introduction. Dr. Parvizi has truly been a giant in our field. He is, arguably one of the most influential orthopedic researchers in history. Has been a fantastic mentor to generations of young orthopedic surgeons, myself included, and has been, has been the research director and the James Edward Professor at the Rothman Institute until very recently. He is now going on to some new endeavors, including opening a surgery center for underserved patients in Istanbul, which I'm very excited about, as well as continuing his work with Parvizi Surgical Innovations. On a personal note, I think what's really impressive about Dr. Parvizi, and most impressive, is his genuine humanity. Dr. Parvizi is one of the most generous and kind individuals I know. I'll never forget when I was a lowly medical student presenting in sort of a half-empty room at AAOS. He took the specific time to seek me out after the presentation and talk to me and congratulate me for the presentation, and just really sparked sort of the, let me know who he was as a human being, and that continued as my time as a fellow under him at Rothman. And so we're very proud and honored to have Dr. Parvizi as our keynote speaker today. Thank you.
Thank you so much, Derek. That's very kind of you. You forgot to say that you're not as good of a tequila drinker as Eric Hansen, so I think that was the only thing he was better at. But it's a pleasure. But you're better at wine, though. So it's a pleasure to be here, and it's a true honor, especially at this juncture where I'm sort of transitioning from my 23 years of being in Philadelphia to a different venture. And as you heard, I'll be going to Istanbul. We've opened a center that will provide care to those in need in that part of the world. And they find it very difficult to travel to the U.S. because of visa issues and costs. So instead of them coming to the U.S., we'll be going to them in that part. And we will be having meetings and stuff in Istanbul. If you haven't visited Istanbul, please come and visit. I think it's one of the best cities in the world. Now, this morning, sort of theme looked like I was really anti-industry, and now I give this talk in a second, you really think I hate industry. I really don't, but I personally think it's very important for us to be mindful of things that have helped our patients and those that have hurt our patients. I really don't have any disclosure related to this particular talk, and I will not be mentioning anything that's not FDA approved. So the talk will be on venous thromboembolism, which applies to all orthopedic procedures. I think it's one of the most feared complications because it can be potentially fatal. And our patients and ourselves are always worried about this. And because of it, there's a whole menu of modalities that we can employ to try to minimize the risk following joint replacement or orthopedic procedures. So I will share some facts and some fictions, and I'll leave it to you to decide which of these are the best for you, for your patients. One of the facts that currently stands, it looks like aspirin and mechanical prophylaxis are probably the best modalities for prevention of VTE following orthopedic procedures. As you might know, in 2022, we had the ICM VTE task force. This document has been published in JVJS, and I'm happy to provide you with the full document, which is almost 1,000 pages, but I will present some of these snippets. That question came up, and what's the optimal VTE prophylaxis? With a very strong recommendation, it appeared that aspirin, low-dose aspirin, is currently the most effective and safest method of prophylaxis against VTE. But I will present to you some of the facts surrounding the use of aspirin. As you can see in the AHKS survey, as we've had that every year, the adoption of aspirin has been seen exponentially increasing, and currently over 90% of orthopedic surgeons performing joint replacement use aspirin as the main modality for prevention of VTE following joint replacement. But we've been seeing resistance from our hematology, cardiology, internal medicine colleagues, and we've also had other clouding issues, in particular the lawsuit, which appears to affect the adoption of aspirin in U.S. and other parts of the world. And we've seen multiple guidelines. Majority of the guidelines are hip and knee related. Other specialties are not covered. There's no global perspective, and there are some contradictory recommendations. These are some of the guidelines that are out there, and I will definitely present those to you. The other problem with some of these guidelines, in particular recommendations by governmental agencies, is that they've been influenced by industry, in particular industry that have interest in the sale of very aggressive anticoagulation. For example, the SCIP guidelines was actually sponsored by Sanofi Aventis that has low molecular weight heparin as their main modality and main cells. CHEST guidelines, the initial one that came, unfortunately had almost all members of their guideline committee conflicted working for pharmaceutical industry, and that unfortunately affected perhaps their recommendations. And we've published showing that funded studies supported expensive drugs when they were funded by pharmaceutical company. And I think that's probably also true to some extent related to devices. Department of Justice has been watching this for a long time. They've issued numerous warnings and fined the pharmaceutical industry for aggressive marketing of their drugs in areas where there have not been studies published. And there's definitely been dirty politics. And Robert Barrick has a fantastic talk that unravels the background related to dirty politics and VTE prophylaxis in this country, which time doesn't allow me to go into. But why did we have the international consensus? Because literature is not definitive, and to be able to really do studies related to VTE, you sometimes need in the tens of thousands of patients. This particular trial that's ongoing with Dr. Pellegrini, looking at aspirin, factor X inhibitor, and warfarin, requires 20,000 patients. And thanks to him, I think we will be seeing a randomized prospective study published shortly that will give us an answer as to which of those modalities are better. The consensus meeting, as you all know, it is conducted using the Delphi method. And the ICMVT document that came out, it wasn't just by orthopedic surgeons. We actually had the endorsement of numerous societies from hematology, vascular medicine, cardiology, anesthesia, and that I think was very, very important. The literature was reviewed by the Cochrane Group and also by our librarians at Jefferson. We went through systematic review and pulled out every single article related to VTE prophylaxis after orthopedic procedures. And we were also able to using artificial intelligence and other sophisticated software to come up with a VTE risk calculator, which I think is the first time a risk calculator that's been internally and externally validated, looking at over 250 different metrics that affect the development of VTE following orthopedic surgeries. So you hear people saying aspirin is not accepted by any guidelines. That's absolutely not true. CHEST guidelines, in fact, accept aspirin, giving it a 1C recommendation both for hip, knee, and hip fractures. This is the new guidelines. 1B, which is the highest that they have, and you can see that that's definitely supported. Academy has always been supportive of aspirin. Scottish guidelines endorses aspirin for the use after knee and hip, and recently NICE guidelines accepted it for total knees, and I believe the total hip endorsement is shortly to come out. You hear people say there's no data on efficacy of aspirin, and aspirin only works on emboli or thrombus in the veins and not emboli on the arterial side and not thrombus on the vein. The red clot versus the black clot. That's not true, especially if you look at the mechanism by which aspirin works. Aspirin is a platelet aggregation inhibitor, and it is very important in disrupting the Virchow's triad in prevention of embolus and thrombus formation. The initial study that came out, which you're all familiar with, is the PEP trial. That was almost on 14,000 patients. And this particular trial endorsed the use of aspirin and made a statement that aspirin reduces the risk of pulmonary embolus by 43% and DVT by almost a third. In other words, aspirin will prevent 4 fatal pulmonary emboli per 1,000 patients. And their recommendation was there's good evidence to consider aspirin routinely in a wide range of surgical and medical groups at high risk of VTE. We published initial studies showing that aspirin was very effective in prevention of VTE. David Beverland from Ireland, who's the Lone Ranger using aspirin in that part of Europe, also published a study showing that aspirin was very effective in prevention of VTE and also in reduction of fatal outcome. This particular current concept review is slightly old now, but it has over 350 references, and over 100 of those endorsed the use of aspirin after orthopedic procedures. So if you're ever in a bind in discussions with your hematology and internal medicine colleagues who are telling you there's no evidence for use of aspirin, you can definitely show them this particular current concept or reach out to me, and I'll be happy to provide as many of those references they wish to see. So there is definitely evidence in favor of aspirin. This particular meta-analysis showed aspirin reduced DVT by 20% and pulmonary embolus by 69%. The PEP trial also showed, obviously, reduction in fatal outcome. Cecilia Beccattini is one of those great investigators in Europe that published her trial in New England Journal of Medicine on 402 patients, and they show a 42% reduction in the incidence of recurrent VTE. And recurrent VTE, these are all thrombotic events and not emboli. Another study that was published on 822 patients showed a significant reduction on major vascular events. The INSPIRE study that was published in JAMA also showed significant reduction in venous thromboembolism with the use of aspirin. There was this trial from Canada that also showed a significant reduction in the incidence of all-time VTE complications after total knee replacement. Another study in New England Journal of Medicine seen the same things. And then another study that came out in JAMA Internal Medicine showing that aspirin did not differ significantly from other anticoagulants for VTE prophylaxis after total hip and total knee. In other words, aspirin was just as good as any other anticoagulant after total knee and total hip replacement. There are reasons for you to use aspirin besides its effect on prevention of VTE. And some of these are its so-called untoward or unidentified benefits. There's been numerous publications from our institution and others showing that the use of aspirin leads to a reduction in hematoma formation, persistent wound drainage, pyrexia, and recent article shows that there's also a reduction in need for manipulation after knee replacement, perhaps because of its effect on, again, on formation of HO and others. Aspirin is as effective as any other agents, and I hope that the trial by Dr. Pellegrini will show that aspirin is superior to Coumadin. So if any of you in this room is still using Coumadin, I will caution you for the use of Coumadin on two accounts. Number one is that Coumadin is a procoagulant by preventing protein C and protein S function in the first 48 hours after joint replacement. So patients who receive Coumadin actually have a higher incidence of VTE in the first couple of days unless another anticoagulant is added. The second is the unpredictable pharmacokinetics of Coumadin, which we are all familiar with. And these patients who are co-administer other drugs will have severe problems with the administration of Coumadin. So my prediction is that Coumadin will actually be discarded and dissolved from the menu books in the coming years, and we will hopefully not be seeing them. I haven't personally administered Coumadin to any of my patients. But it's very important to individualize VTE prophylaxis. Not every person is at the same risk. Recent studies showing that medium to high risk patients also do as well with the aspirin, but if you're a skeptic, then at least you can adopt aspirin in the low-risk patient population initially, and once you observe its effect and its safety, you can then broaden its use to the medium and the high-risk patients. But currently, if you have medium to high-risk patients, I think perhaps the factor 10 inhibitors at half the dose are the best options to consider for these patients. I told you about the VTE risk calculator that's available on the on a free app that you could certainly use, and it's under the ICM Philly app itself. It looks at numerous risk factors for VTE and will give you a fairly accurate percentage potential for development of venous thromboembolism. Currently, we give aspirin, 81 milligram BID, to patients, not the chewable aspirin. This year in AUKUS, you'll see a paper by other investigators showing that not all aspirins have the same efficacy. So this should be the non-enteric coated aspirin, given for 4 weeks. And if your patients are unable to tolerate it beyond 2 weeks, I think it's perfectly safe to stop the VTE prophylaxis at that point. We did a crossover study looking at aspirin at low dose versus high dose, and we didn't see a difference between the two, but the GI tract side effects were higher with the higher dose aspirin. So aspirin at the lower dose is more effective and less adverse events associated with it. If you have a high-risk patient, your options are to either administer the anticoagulant yourself, again, factor X inhibitor at half a dose. One of those actually seems to be much better than the others, or you could send them to hematologist or internal medicine for evaluation. But as I'm coming to the end, let me tell you a couple of other facts. There is no absolute prophylaxis. I get asked to go to the court to protect doctors who've given the choice of anticoagulants that they felt was the best for their patients. If you are a surgeon with a high volume, you will see a patient die of pulmonary embolus, regardless of whether you gave them low molecular weight heparin, factor X inhibitor, fondaparinux, or aspirin. Unfortunately, this relates to issues, in particular genetics, and I think the issue here is that we have to do what we think is right for our patients, and in the process be able to defend that both ethically and legally. But another fact that's very clear is that the administration of aggressive anticoagulants in themselves may kill the patient. And they may kill the patient as a result of hematoma formation in critical spaces, including the brain, or they may kill them as a result of loss of blood, anemia, and the cardiac events that may ensue as a result of aggressive blood loss. Nigel Sharrock's work from HSS on on 28,000 patients, looking at 20 studies, showed that the mortality was higher with the administration of potent anticoagulation. So in your good intentions of trying to prevent VTE, you could potentially push the patient to the other edge and have them die as a result of acute blood loss. Fatal pulmonary embolus has not changed over the past 3 decades, regardless of what anticoagulant you administer to these patients, still remains exactly at a constant rate of almost 1 in 1,000 to 1 in 1,500 patients. And part of it is relates to the genetics, but part of it also relates to the administration of aggressive anticoagulants. And this particular study found that mortality was higher when low molecular weight heparin was given. On top of that, there are issues related to hematoma formation, which has been found to be a grave complication following joint replacement. And our internist colleagues and hematology colleagues and the others that, again, they mean well and they want to do the right thing for our patients, are unaware of this particular complication because they're rarely asked to go to the operating room to evacuate a hematoma. And once you see these patients develop hematoma, develop periprosthetic joint infections, unfortunately, their lives change forever. Studies here showing that the administration of aggressive anticoagulants lead to increase in persistent wound drainage, wound-related complication, readmission, reoperation, periprosthetic joint infection, and all-time mortality. So in this day, and with the modern data we have available, I will find it very difficult to see how a person could justify administering aggressive anticoagulants to patients undergoing routine primary joint replacement. And aspirin is probably the best and the safest drug to be given to these patients. So again, no change in the incidence of fatal pulmonary embolus over the years. And if you look at the Australian registry, in fact, patients who were administered mechanical prophylaxis with nothing else had the best outcome in terms of mortality. This data is also being reflected in the Swedish registry and other registries that we're following very closely. But we do need to identify genetic predisposing factor to our patients who do develop recurrent pulmonary emboli and who are at risk of dying. And these patients would probably benefit from other modalities, including the use of filters for prevention of fatal emboli. So I hope this has been of some use to you. I hope that you will consider the data that's out there that endorses the use of aspirin for the majority. And moving forward, I think adoption of aspirin is the main modality, not only safest and more effective for our patients, it will have a huge economic impact, particularly in this day and age where it seems to be that we are under huge financial pressures. Thank you very much for your time.
Jay, thank you. Thank you for a great talk. And Craig Hogan, I'm from Colorado, and due to all your work in this space, we've been able to adopt a risk-stratified aspirin-based protocol. There's a little bit of literature from the Stedman Clinic in Vail about the potential higher incidence of VTE elevation. We've been unable to try to get with our colleagues in Utah and New Mexico to really look at that, but just curious your thoughts on that. We currently use a slightly higher dose of aspirin instead of the twice a day. We just do it all at once at 162. But what are your thoughts on elevation and VT risk?
Yeah, there is definitely literature from cardiology showing that hypooxygenation and an environment where obviously in mountains where you are seeing elevated hemoglobin levels, it increases either by viscosity or other means, slightly increases the VTE risk. So I think that group of patients could benefit from being your anticoagulation being individualized, and higher doses of aspirin, 160, I think that's perfect. The PEP trial was on a 160 BID also. So I did also see a study from Intermountain Group a while ago showing that aspirin wasn't as effective in their patient population compared to other modalities. So it's an area I think that requires further exploration, but certainly patients with a higher hemoglobin level, those living in a higher altitude, are at a slightly increased risk of VTE. That's a great question, Craig.
Thank you for your talk. I had a quick question just about what you use in some of these high-risk individuals currently. So say you do a total knee on somebody, they have a symptomatic PE, and then 1 year later they're back for their next total knee. What are you using for DVT prophylaxis in that patient?
Sure, Keith. So one thing is we don't use bridging. So these patients don't need bridging. They will get admitted on the day of surgery, and I will put them, again, I'm not conflicted, I'm not selling a drug here, but I will put them Eliquis 2.5. I think based on the clinical trials that I have seen, Eliquis seems to have like the least of side effect profiles. At the 2.5 milligram for 2 weeks, and then they will go on a full dose Eliquis for another 2 weeks, 4 weeks. Now, these are patients who are high risk, and by high risk we mean they're sedentary, they're undergoing major operation, they have some of those risk factors. The complicating factor is some patients that come to us who are already on an anticoagulant, either a platelet aggregation inhibitor like Plavix, Coumadin, or maybe even factor 10 inhibitors. The protocol we have currently is to stop those about 5 days prior to surgery in order to be able to administer them local anesthesia, and then put them on half a dose of what they were on for a week, and then bring them back to the full dose. Most of these patients are obviously on anticoagulants because of underlying dysrhythmia. The Plavix protocol is being revised by ASRA guidelines. This is the American Society of Regional Anesthesia. It looks like maybe Plavix will be we'll be more liberal with Plavix in the future, but factor 10 inhibitors, they definitely prefer that stopped at least 72 hours, but preferably 5 days. So that's our current protocol related to aggressive anticoagulation. Now, multiple DVTs, unprovoked particularly, multiple pulmonary emboli, and patients who've had a family history of pulmonary embolus that may or may not have been fatal, in my opinion, are high-risk patients with genetic predisposition, and I would put those patients on factor X inhibitors. Stefano.
Jay, thank you so much for terrific covering of this amazingly difficult, complex topic. You make it sound simple. Thank you for that. I have two questions, if it's okay. One on factor X inhibitors, and one on how you approach revision hip surgery or knee surgery. The first one is, as I recall, the factor Xa initial studies were done with the administration of the drug 12 hours post-op with massive problems with postoperative bleeding, and so they were held. So everybody went to 24 hours, but I don't believe that there was ever any studies showing efficacy at 24 hours. Is that correct?
Yeah, so that's the record trials. You're absolutely right. And that particular trial is on Xarelto. Again, I have no connection to any of these industries. I'm bringing these names out because I want you to sort of know the difference between them, subtle differences. Xarelto had very high rate of complications when administered at 12 hours. Eliquis doesn't. So we do administer Eliquis on the day of surgery when the patient is either going home or staying. If you were to do Xarelto, particularly at the full dose of 10 milligram BID, I would be a little careful of starting on hour 12. You're absolutely right. That record 1 and record 2 trials showed very, very different outcome when they were given early, particularly related to persistent wound drainage.
And was there any follow-up data to see that it remained as effective as expected at 24 hours?
Yeah,
or just an assumption?
That's the assumption. But fortunately, what is known about factor X inhibitors is that they are not procoagulant.
Yeah.
They go after the extrinsic pathway. But Coumadin is a procoagulant because it actually does the reverse to start with. So 24 hours is a little uncomfortable, but we give intravenous heparin to our patients during the surgical procedures based on data from HSS, which I think does change the equation slightly in the favor of reduction of VTE event. If you're not given intravenous heparin during surgery and you're waiting for 24 hours, I would be a little worried.
Second question is around how you change your protocols either for length of surgery, very complex primary, or a difficult revision. That's something that I don't think has been well.
Yeah, so we didn't have data on revision. We are presenting the data on almost 30,000 patients from multiple centers this year at AHKS, and there seems to be no difference when you're giving them anticoagulants or whole classes versus aspirin. So it looks like aspirin is very effective in this patient population. The other patients that we were worried about, which we know have a higher risk of VT, are the bilateral joint replacements. That data came out. It looks like they're at a slightly higher risk of VT regardless of what anticoagulant they receive, but aspirin seemed to function just as well as the others. So in the bilateral group, we'll give aspirin. Revisions, we'll give aspirin. Complex conversions, we'll give aspirin. But unless they have a pre-existent history that I was telling Keith about. So I think aspirin is still fine in that patient population. And in fact, you could argue some of these patients with like megaprosthesis or complex revisions that you did, hematoma would be a very, very significant event in that patient population. Imagine a total femur that develops a hematoma. So in this patient population, if anything, I would be leaning more towards a less aggressive anticoagulation than giving them the others. But that's a great question.
Great. Thanks for your talk. I'm Eric McDonald I'm currently working on a Kaiser. What's your change in your protocols for recently COVID positive patients? Is that making a difference? Are you seeing anything change from your protocols in that standpoint?
Yeah, we're looking at that data currently, Eric. Great question. We know that COVID itself increases the risk for all type of thromboembolic events. Whether that translates to pulmonary embolus, particularly fatal pulmonary embolus or not, we don't know. But we are looking at, again, a multi-center study looking at the stats of the patients. The thing that we're finding it complicating right now, and I'm not sure if we'll be able to ever dissect that data out, is that there are patients who had COVID who didn't know and didn't get tested, and then the proximity of the event to surgery. If you had COVID 2 years ago, now you have a knee replacement versus 6 weeks ago, and now you have a, so that's another complex issue. And then the third issue, I think, relates to administration of vaccine, in particular, which type of vaccine. So patients who were vaccinated versus non-vaccinated, patients who were vaccinated and had the COVID either before or after the vaccine. So these are like complicating factors. So right now, to answer your question a long-winded way, I don't know. We need to get that data and to see what happens. But there's a lot of subtle COVID conditions that probably don't get detected, and some of these patients could be at risk. Great. Thank you again. Thank you for inviting me here. I appreciate it.